Welcome to the new world of progress, mutual respect, and good health. I'm Robert Steven Kramarz, Executive Director of Intelliversity, the innovation accelerator for the real world. For example, we work with venture capitalists to make sure that the most amount of capital is transferred to the most effective founders, those we call vision masters. Our most important project now is Project Jericho, which is based upon the fact that collaboration in healthcare is made possible by a common language, that's the language of medicine, a common culture, the culture of science, and a common set of felt needs, the need for greater vitality and reduced suffering for ourselves, our families, and our communities. So with this in mind and inspired by the Abraham Accords, we now think that 3 or maybe 4 major goals are possible. Greater win-win economic growth throughout the Islamic Middle East, higher levels of medical outcomes throughout the Islamic Middle East, knowledge transfer of the latest treatments to these ends, and where possible, conversations that may lead to negotiations to achieve peace agreements that were not possible before. So we're proposing a modern medical tourism facility to be constructed in or near the town of Jericho, which, as you know, is something of an oasis in the Jordan River Valley. It's to be staffed entirely by Palestinian doctors, nurses, and assistants. It will be informed by science from the United States, Israel, and elsewhere. It will provide the most advanced cancer care, and it will serve the entire Islamic Middle East, including both the Gulf states, Palestine, West Bank, and Gaza, North Africa, Jordan, and the other countries. Now we understand that such a project is very challenging. So we're here at C3 Summit to request your advice, your feedback, your suggestions, your ideas, and if possible, your assistance. And we also invite you to consider that your own goals and your own projects be achievable in the real world so that we can also call you a vision master. Thank you for your support.
Thank you very much for that. With that, I'd like to introduce Robert Kramarz, who, as you see, is the Executive Director. And with that, it will be on medical tourism as a means to knowledge transfer and an economic win-win for the Middle East. So Robert, I'll turn it over to you from here.
Those videos are never as good as you think they're going to be when you record them, right? But it's good. Thank you, Ransel, for the kind of the segue from the prior panel, because it was actually quite a good segue, because telemedicine actually makes medical tourism, in the way we think of doing it, is more feasible and rather than less necessary. Because we usually think of medical tourism and healthcare diplomacy broadly as 2 separate topics. Because if you're going to travel to the Cleveland Clinic or anywhere to get some procedure done, then that doesn't actually accomplish anything for diplomacy or for regional development. It just helps the patient and the clinic, which is all good. But so the concept that we're developing innovatively is to solve some of these problems in medical treatment on a regional community basis, so that there is still travel or medical tourism involved, but not necessarily to the United States. But so instead of traveling to the US, the tourist travels to Neom, or they travel to Jericho. And this would be possible in certain kinds of cancer care. Obviously, not every procedure can be handled that way. And naturally, the usual use of medical tourism for, say, 1 or 2 day visits for a knee transplant, or possibly a week, that's going to continue throughout the world. That's not going to change. But here we're talking more about the kinds of needs for cancer patients that have a need for a 2 to 6 week stay, where they need family support. In fact, where really faith becomes a large factor and family support becomes a large factor in their recovery and their ability to deal with it. So for that reason, we're proposing this Cancer Medical Tourism Center in Jericho. And I thought, before I go on to our guests, which I'm really looking forward to hearing from, I just wanted to show you some quick pictures if I could share a screen here. So give me a moment here. This should do it. So can you guys see this picture of Jericho? Yep, good. Okay, so it's not all that green, but it's actually a very lovely area near the Dead Sea. It's perfect for a resort. It happens to be in Palestinian administered territory, and it's a culturally appropriate Arabic-speaking area. And when we get right down to brass tacks, it may be that we do this project someplace else. So we're just using this Jericho as an example of a place that we could situate such a center. Here, if you look at the West Bank, where you can see where Jericho is located. You can't see Amman, but it's about 50 kilometers into Jordan here, so it's about the same distance straight by road from Jerusalem. It's a central location because, let's take another look, a little bit broader. You have Lebanon up here. It's not, the drive is actually straightforward right up into Lebanon and Syria. And then if you look at a bigger map, more zoomed out, you can see that Jericho, which is right there in the middle, this is actually a 260-kilometer drive down to Neom, which is right down here, slightly off the map in the bottom. And as I said, it's a 50-kilometer drive into Jerusalem or to Amman. Here's a bigger picture, more zoomed out. So just to give us the broad picture of the whole idea is to provide some of the services that you'd otherwise have to travel much farther, right within the Middle East, and yet not necessarily in the Gulf states, but more over here towards the resort areas on the Mediterranean, and in cooperation with Neom, I'm hoping, which is right down there just below Jordan. So here's an example of the bridge between Israel and Jordan. It's called the Allenby Bridge, and this was 1967. Didn't look too good, right after the war. And here's the current state of the bridge. It's very active, very busy. It's a whole new world of collaboration. Unfortunately, the peace agreements between Israel, Jordan, and Egypt haven't led to a great deal of collaboration. It's just an opening. So we think that we're hoping that by doing the collaboration first, well, now the Abraham Accords have actually enabled this kind of thing, but doing collaboration in the area of medicine is truly a way to create a foundation for agreements, rather than just a consequence of those agreements. So that's really what I wanted to share with you in terms of visual imagery. So I'm going to stop the share. I hope that was clear what we're trying to do, but if there's any questions from the audience, we'll take that on in a moment. What I wanted to do is introduce our panel members. I'm really proud and pleased to be associated with you guys. Dr. Ghassan Abou-Alfa from Memorial Sloan Kettering. Cancer Center is a wide range of interests that overlap and coincide with mine. We've had a good time together talking about many areas. And then we have Dr. Mark Davis with Brigham Health International, which is a similarly highly placed cancer center in the general Boston area. And Mark is the Executive Director of Business Development and Strategic Initiatives, which is a perfect fit for what we're talking about. He's also an Associate Professor of Emergency Medicine at Harvard Medical School. That's a very challenging area, Mark. First of all, thank you for, if you get a call in the middle of this, we'll understand. That's fine. And then working closely with you, I know, is Dr. Marcelo Montorzi, who is a lead physician at the International Patient Center. So his direct experience with the medical tourism business. And I know that Brigham is kind of a complex organization that's associated with Harvard and yet also separate. So some of those relationships are new to me, but I'm sure they're not to you. So you'll have a chance to talk about that if that comes up. So why don't I allow each of you to speak for a moment on what your institutions are doing in the area of medical tourism generally, and then we'll bear down onto the specific issue of the Jericho Center as a way to illustrate some new ideas, that we can implement together that aren't in the current agenda. And that I think will be very interesting to the audience to take be open-minded about what's possible. So Dr. Abou-Alfa, for you first.
Thanks so much, Rob, and congratulations on all the great efforts. It's so nice to see the video that you presented, and greatly honored to be with you and with Mark and Marcelo on this important panel. I have to admit that the word medical tourism is not necessarily fully understood by many of us, because the perception tourism for me is like sitting on the beach, and at the same time we're talking here about like a industry, but I like very much what you brought up, which is you're carrying this industry to another level, and you brought up a very important component of medical diplomacy. At Sloan Kettering, of course, we are open to the whole world, and patients are most welcome from wherever they are, and understandably, if they are appropriate patients that we can, in other words, appropriately help, by all means, we welcome them at our institution. We don't have presence, or rather a brick mortar presence anywhere in the world, but by all means, we depend on our collaboration with all our dear colleagues, and understandably, if they see that we can be of need, we are more than happy to help out in every way we can. However, this is not necessarily reflective of the whole thing that we do globally, because as we all know, Sloan Kettering has really a three-pronged approach. The other two are education and research. And if anything, we pass on our education literally all over the world. We have literally monthly conferences that we do that travel all the way from the Middle East to South America and whatever is in between. And at the same time, we do others with Asia. And we have noticed that this really can bring in the collaboration even further and enhance, number one, make sure that physicians are learning from, and we are learning from them too, how to apply what's best for their patients. The other components and important is the research. Because after all, nowadays, because we subspecialize in cancer, we have a clear understanding that cancer is not the same wherever patients are, i.e. a patient with breast cancer in the Middle East is not the same as a patient with breast cancer in downtown New York. And if anything, a genetic understanding of those diseases is very much needed. And that's really where our collaboration on those two venues, being research and education, indirectly and appropriately so, enhance our at least one-way medical tourism, where we are definitely welcoming the patients that we can be definitely of help to. I definitely can see that there's a lot of potential and a lot of future. That's really why we continue to talk to everybody and to see how we can help in every way we can.
Thank you. Thank you very much. Dr. Davis and Dr. Montorzi.
Well, good morning. A pleasure to be here with everybody. I have to say, when I saw the panel topic, I was really pleased to see it. I think, Ransel, that this brings us back with C3 really to the beginning about what's the overarching opportunity here. It's advancing healthcare, it's using healthcare, leveraging healthcare for the greater good. And I thought what I'd do this morning is take just a moment to reflect back on some of the work we do in this regard as we think about advancing health and developing relationships, that a part of which certainly is medical tourism. But just very briefly, we've spoken so much about COVID. What was the world before COVID? What's it going to be after COVID? What's the context in which we talk about these various items? Let me, one moment, please. So just to give everybody a reminder, before all of COVID, we were in really a very interesting place, right? Global health, the improvements in global health over our lifetime in the last decade has really been remarkable. Life expectancy worldwide increasing by 10 years from 61 to 71 years, healthy life expectancy increasing, trends in global disability adjusted life years improving, looking at a whole new structure of burden of disease, however, looking at chronic diseases as we had thought that we had done so well addressing communicable diseases. Of course, we've learned that they can still poke their head up and really change our lives. Looking at the expansion of the middle class, why are we able to make many of these health advances that we are making now? Really a remarkable another achievement that as of this year, prior to COVID, the majority of the global population was in the middle class. And you put together these different factors and you see the opportunity for really global change. And I have argued, as many have, including Ransel and Robert with your great project here, that we should be using healthcare in ways that are really much bigger than simply some of the narrow ways that we sometimes look at it. So collaboration in health has a number of different opportunities. One is shared patient care, and I would argue that the patient referral opportunities in health tourism is really an opportunity to share in patient care with local providers, that we have an opportunity to work together in crises and humanitarian work. And many of us worked in this very area, as Robert and I were saying, in a Peace Through Health initiative between the Israelis and Palestinians starting 20 years ago at times of great conflict and working with others in the region. Looking at facilities design, operational design, how can we teach, how can we do research together? So I think this all fits within this larger context of a changing world, an opportunity to leverage health in new ways. Some of the ways that these collaborations look include strategic planning and hospital and facilities planning development. And I know many of my colleagues on this call, including Ghassan and international colleagues, those at Cleveland Clinic, we usually travel together as we talk about doing these different collaborations. Here, technology has made it a little easier, though I do really look forward, as the previous panel was talking about, getting back together in person. Mm-hmm. But working together in areas including hospital operations, program development with our colleagues around the world allows us to create the relationships that improves care locally, which I think would be an important part of the project that we're discussing here. And also at the right time, patients will travel to us at Brigham and Dana-Farber Brigham or MSK or Cleveland Clinic or any of the other fine institutions here or internationally, but then go back for their local care.
Yes.
Speaking about collaborations, I look at this in terms of relationship building that in fact, conflict mitigation is a part of all of this. And if we look at conflict as a disease, then part of the treatment of this disease is really building these relationships. And we look over the years, it's really about expectations, working in other places in the world. If the expectation is that things are not going to go well, that's what happened. With higher expectations, we look at building new facilities and new opportunities. This one happens to be in the southern part of China. So with that, I will lead to the opportunities I think that we have here in this sort of collaboration and really finalize. And I know there are a number of groups on from China as well. And look back at what President Colin Powell talked about in terms of healthcare at SARS at the time, is upon such concrete forms of cooperation on issues of regional and global importance that a 21st century US-China relationship would be built, issue by issue, experience by experience, challenge by challenge, initiative by initiative, program by program. So in fact, health really can and should be the center of moving us forward in many different domains. And thank you for the opportunity to be here.
Thank you, Dr. Davis. By the way, it would be very nice if Colin Powell actually had been president, but that isn't the way history has worked out. I think you said the President Colin Powell, which is...
Oh, as President Colin Powell, well, you know, we can only hope, right?
We can only hope, right? So, and your associate, Dr. Montorzi, what can you add to that about medical
Thank
tourism?
you. Thank you very much for the opportunity to participate of this forum. Yeah, I want to mention and start with a question with a teenage girl by the same clothes as her grandmother. Probably not. However, both, if they get sick, they will receive the same medical treatment despite their many differences. These differences must be known to their physicians anywhere in the world, and the identification of these individual characteristics requires collaboration among all the involved professionals and organizations. So this brings us to the concept of personalized medicine or precision medicine. There is a tendency to use precision medicine as the preferred term, and precision medicine is perceived as a more technical expression. It implies identifying individual factors that would alter a medical decision, either by prevention, interpretation, or treatment. And in this particular field, there are many domains of meaningful information, and they include environmental piece of information, political, cultural, social, psychological, biochemical, genetic, and epigenetic. For any patient that comes to the Brigham and Women's, and as a matter of fact, to any other organization in the world, the accrual of this information in all these domains requires time, effort, dedication, and access to technology. The only way that the physicians involved in the care of these patients anywhere they are in the world can access to this information is through collaboration. The gathering and the sharing of this cumulative information on each patient, where they come from, the political situation, where they come from, the genetic composition, the particular experiences with different medications, the familiar environment, all that creates a constellation of information that will help the doctor to achieve a medical decision for that particular patient. This intercommunication and collaboration among the global physicians for that patient is crucial for a precise medical plan of action.
Brilliant.
We see telemedicine as a tool, only as a tool that will assist a doctor in a medical decision process. The execution of that decision, of course, will depend on the license within the jurisdiction where the patient is located, but it's just another tool. And the execution can be carried out either by a local physician or the telemedicine doctor, depending on other factors. But collaboration, in our view, is at the core of patient care. That is perhaps the most important element that we're trying to convey. This brings us also to some potential objectives of an international initiative. One is to create a collaborative partnership between academic centers, healthcare organizations, industry overall, governments. The flexibilization of some international regulations, the interoperability of electronic medical record systems so that we can exchange information easily and fast between different places in the world. The design of tools for sharing real-time patient data in a protected manner. The design of tools for building, for analyzing, for sharing large sets of medical data in a protected manner. And ideally, to allow immediate access to specific medical information as part of the routine medical care anywhere in the world where that patient is, either in the United States, in Palestine, France, you name it.
Thank you, Dr. Montorzi. So before we engage in a general conversation, I really have three questions for each of you. And somebody from the audience said that my mic wasn't high enough, so I'm going to talk a little louder. If it's too loud, just give me a signal. This whole concept of medical tourism, when handled on a local or regional basis, rather than traveling around the world to get your care, requires, it seems to me, exactly what you're talking about, Dr. Montorzi, which is collaboration through telemedicine of specialists wherever the expertise lies and the local physician who can't possibly have as much experience. On the other hand, and it's interesting, Dr. Abou-Alfa pointed out to me yesterday that the genetics of the Palestinian people, there's actually at least two different pools, genetic pools, and the epigenetic are different than what you might find in other regions. So if you're treating, all your patients are from the Middle East and many of them are Palestinian or Gulf state residents, you're going to find a different constellation of genetic and epigenetic factors, as well as cultural factors, that would guide you, right, and change possibly the use of which chemotherapy drugs are used or which immunological treatments are used, how the course of treatment might unfold, right? So there's an advantage to having a medical tourism center for cancer care, specifically located regionally rather than requiring transfer of the patient to another all the way across the world. Is that, so my first question to you is, do you agree or do you disagree or something in between, and why? That would be for all three of you.
So this is Ghassan. I might start, and if you allow me, I will share my screen. I'm just going to show a picture or two of really what you are referring to, Rob, which is quite amazing. And this is actually what we call the bottleneck drifting in regard to how genetics would evolve. And this is a kind of a depiction from Brazil showing about how the different population might evolve together. And within that context, you will notice that the genetic maps are way too complex, and is not here to do a medical lecture over here, but this is really just talk about, like, for example, where the oldest conflict in the world is, it's between Pakistan and India. And you will be amazed to see that there's a lot of differences in regard to the genetics between India and Pakistan. But interesting, when you look at North India specific, you'll see that the changes are pretty much the same. And when we jump on to, and this is really the thing in Pakistan and India, but if we jump on to the Middle East, that's even like more shocking. And as you can see here among Ashkenazi, Egyptians, Syrians, Yemeni, if you look at the first line, you will see that actually the same numbers are there. It's exactly the same mutation. And if anything, just tell you how much we are the same people. So if anything, our perspective is really what was looked at in one of the nice piece of work that came out of Israel that looked into ovarian and breast cancer among the Palestinians, and found out actually that among Muslim Arabs, Christian Arabs, and the Jewish population, there is some difference in regard to what diseases they would incur from the same mutation. This is like work that was never evolved onto further than that. And if anything, we're coming to really an audacious project that we proudly are moving on from Memorial, where we'll be having a joint conference, hopefully that will welcome at Memorial, to discuss and define germline alterations, gather similarities and differences among different populations. This does not apply specifically to the Middle East, but the Middle East could be a great start because especially of the necessities that you brought up. Building the relationship and communication channels, means for sharing clinical experience, sharing tissue samples and data, and of course, research infrastructure. And we like to do that conjointly with a political and public affiliation and a relationship effort that will inform the participant nations leadership about the project and garner popular support. Because as you mentioned, it's very important to really gather that normalization of the relationships, and that really could be a great example of that.
Thank you.
But
Dr.
I
Davis,
would say,
Dr. Montorzi.
Rob, that I definitely agree. And there's really the two purposes. One is the concrete specific medical purposes to which you and Ghassan are alluding. And then there's sort of the superordinate things, which may be even more significant. The idea that locally that people will do these things together with the support, and sometimes that outside support makes it not only possible or financially, but it makes it really a lot easier. So I think the notion of doing this is critically important. It will have very practical implications, as you suggest, and also much larger implications.
I agree, Rob, and I agree with Dr. Davis and also with Ghassan. I think that collaboration is essential. There is no single place in the world that is the best for all the patients. Having immediate, real-time and local access to first-class medical care for those patients living in the Middle East will be essential. And the important thing is that now, with the open lines of communication and collaboration available with referral centers, the patients not necessarily have to travel in order to get immediate first-class care. The project, I think, is very important, and it will provide benefits that will go beyond medicine in that community.
Thank you. It's interesting. There's really two classes of clients we're anticipating. One are the Palestinian clients. What one forgets when we're talking about medical tourism, we're thinking about wealthy people or affluent folks. But right in Palestine, you have a very large population of refugees, and several million, right? And a lot of other people are simply living below what we consider a standard of living. In Gaza particularly, and these people get cancer just as much as anybody else, right? So, and they don't have access, they can't travel to the US or any place for that matter. So part of the purpose of this is to make cancer care at a high standard of care available to these populations. And at the same time, to provide certain kinds of cancer care that wouldn't be available locally to the Gulf states and to some of the other affluent areas. So my second question is, and this is really exploratory, I need your support on this. Which areas of cancer care do you think are possibly the most experimental, are just not available presently in the Gulf states that do require travel at this time?
Well, Rob, there's plenty of those, and it's not because there's no ability or limitations of any kind. It's simply because they are new and they got to evolve somewhere where they are being developed further. And I would say that if we were to aspire high and look into cure, and this is really what we would like to all go. Funny enough, 20 years ago, none of us would even dare talk about cure for cancer, but nowadays we do. And I think CAR T cells is definitely where the future is. And patients do come from the Middle East, or they come from many other parts of the world to mainly the US for the CAR T treatment. And by all means, having CAR T ultimately established wherever the patient is definitely something that we could look for. And at the same time, a very important particularity to this, which is exactly what I just spoke about beforehand. CAR T is not like a one size fits all. It's going to depend on specific antigens or specific markers that's put this way on the cancer cells. And these can differ quite a bit between populations. And that's why you get to do research where people exist and based on the people where they are. Same thing applies for therapy. Remember, nowadays, as we all know, we give therapy to patients being either in the Middle East or in other parts of the world where research is not done, like, for example, Africa. This all research is dependent on clinical trials that were done in the Western Hemisphere. What does it mean to the other patients? Not really much. We are treating patients in Africa based on some data that was built based on Western Hemisphere patients. And this might not necessarily apply. That's really where the necessity for doing the research where patients are.
That's very interesting. So, Dr. Abou-Alfa, my mother, I mentioned this the other day, died of liver cancer, which is your specialty. It was secondary, so she started out in colon. And after standard care was applied, she didn't recover. It was complex, and she was old. But so we enrolled her into a clinical trial in an immunological treatment. Well, I'm positive that was not available outside of San Diego at the time, which is where she lived, or outside of the Southern California area where the clinical trial was underway. Does it make sense to offer clinical trial treatment in the Middle East, wherein the original research was being done in the United States or some other country? Is such a thing even practical?
Absolutely. Clinical trials are very critical because opportunities for patients are dependent on what we ultimately learn from the clinical trials. Always when you try to approach patient regard to clinical trial, of course, you're trying to help the patients, but you also have to really bring into the patient that kind of sense of purpose that they're helping others as well. And this is the only way to advance science. And as we just said, to fascinate you a little bit about the Middle East, for example, there's a certain deficiency in the Middle East that many people have in the different countries that we're addressing, called G6PD deficiency. If you heard of the disease favism, you eat fava beans, they will hemolyze all of their blood. Believe it or not, these patients might have colon cancer, but there's already quite a bit of data that G6PD deficiency might alter how colon cancer can evolve. You're not going to do a G6PD deficiency colon cancer study in New York, but this is really where you got to do it in the Middle East.
So research fits in very well with the treatment model. It's essential, actually, particularly in cancer where there's deep genetic differences between outcomes, different treatments and outcomes. All right, so that's, Dr. Davis and Dr. Montorzi, do you have any comment on the use of clinical trials that are currently underway in the US in the Middle East?
So it's a question that comes up a lot in our global work, and I'm sure Ghassan and our other colleagues online have worked through this many times. I would say that as we look to develop programs like this, my advice is, as you're doing, is to figure out what's the incidence of disease, what are the unmet needs, think in terms of what sort of capacity can be realistically developed and over what sort of time frame.
Yes.
And then leverage the most important parts of collaboration that are most easily achieved. So I think in the cancer realm, my experience is that one of the most important things to do early on is to create a compliant telepathology program. And I'm curious about Ghassan and Dr. Montorzi, your experience, but our experience has been that up to 20% of the time, the pathology slides that come to us are incorrect in that we change the diagnosis and treatment. So you can imagine setting up a center initially that really focuses on even getting the diagnosis correct.
Yes.
So the next part that I think is really critical is, as was mentioned before, the whole idea of personalized and directed medicine. So
Yes.
Getting the diagnosis correct, then being able to apply the correct treatment, whether it happens locally or it leads to travel, I think is really critical. So I agree with Ghassan. We share the same experience. The opportunity to do research, to do clinical trials in this environment is extraordinarily exciting. It is complicated, but very important.
It's interesting because clinical trials require a lot of follow-up. So if someone were to travel to New York or Boston, get chemotherapy and then go back again, you can't do the follow-up, right? If it's experimental clinical trial, right?
I'll let Dr. Montorzi comment on how we do that. Marcelo?
Sure. There are some situations in which the patient can be followed when they go back to their countries, and other situations when the patient cannot be followed. It depends on the agreements. It depends on the company that is sponsoring the study. We have had patients who have been able to go back to their countries and to continue participating of the trial, and other patients that unfortunately were not able to continue. Some of our patients, they stayed in Boston for length of time in order to continue with the treatment.
Now, of course, eventually we're going to have to choose one area of specialty to start with. Maybe it'll be breast cancer, and maybe it'll be something else. Not sure yet, because that's going to be dependent on the areas of expertise available and what the population really needs. But specifically in the area of women's issues, how do you think a center such as we're describing here, which is not directly in the Gulf states but is nearby, might be useful for women's issues? I know I popped this question on you. I didn't prepare you for it, but
well, I have to tell you that we did a project a number of years ago in women's health,
yes,
between the Israelis and Palestinians, Jordanians, and others, and there are very important cultural aspects to doing this.
yes,
On the other hand, I can't think of another project that we had done in that context that was more warmly embraced and critically needed. So my experience in this area is that, as with all of our activities in the areas around the world, it requires a nuanced cultural perspective and
Exactly.
respect for differences.
Yeah.
But that's been my experience in women's health in the region. I don't know, Ghassan and Marcelo, what your experience is.
Well, thanks so much, Mark. I would like to go back to, there are 3 points which you really refer to, which are very critical. Number one, I 100% agree with you in regard to pathology. And no doubt there are, however, very important assets that are available in regard to pathology and understanding disease, especially among the population that Rob is interested in, which is the Palestinians. And 30 minutes by helicopter down to Neom. If you go north to Beirut, the American University of Beirut, which is like a world reference in regard to pathology and the other opportunities that they can provide. And hopefully if borders will open one day, 4 hours drive up or 4 hours drive in. So you are really kind of, I don't know, but you had really a clear vision to place it in Jericho. It's a very important kind of...
Also, east and west, you have Amman and Jerusalem. So
Exactly. And I was going to say that. So perfect location. And that's really very important. And we should not forget about the American University of Beirut that can really provide important opportunities over here. Number two is, in regard to what, again, Mark mentioned, by all means, this is a very critical component that we have an obligation towards in regard to taking care of the malignancies among women. And if anything, this is really an important component that really, if anything, I personally say beside the medicine component, which is critical, it's really a very important diplomatic component, because we kind of notice that in medicine, it's incredible how much parenthood come before anything else. This is like probably one of the most important bonding, innate feel that we have, same like, you know, anybody else in the world. And that's why it's important to really use this as an opportunity for ultimately mediate the peace through that normalization per se. And thirdly, in regard to your point about like, where do we start? Amazing that we were thinking about cancer based on organs, breast cancer, colon cancer, prostate, lung, but there's a lot of commonalities among those cancers.
Yeah,
There's a lot of approaches at the moment that we call agnostic, i.e. we don't look where it's coming from, but we look more where the genetic changes are. Because can we treat, for example, brain cancer, same like a bile duct cancer in different people? Believe it or not, yeah, actually we just did this. We published that report less than a year ago. And here we are, like, you know, based on specific mutation, you can treat leukemia, brain cancer, and bile duct cancer in the liver the same way with the same therapy. Incredible. This is where we are.
very interesting. Yeah, and that's all genetic based, because it
Correct.
may not work in a different individual. So personalized medicine, and you also call it precision medicine, is becoming really quite mainstream in cancer care, and probably in other areas as well, where you have to do a rifle shot approach with knowledge of exactly which mutations are at work, right?
I might interject here again, and this is a very important point. Actually, one of the projects that we proudly have been running for more than a decade already from Sloan Kettering in collaboration with the American University of Beirut. The American University of Beirut has probably the only tissue bank in the Middle East where we actually made sure that the tissue remains at AUB, but believe it or not, all the data is entered electronically and is stored here in New York. And if anything, all genetic analyses is done there and just kind of transmitted electronically information-wise to be analyzed and collected here. Because after all, the technology is not a big deal. You can bring it anywhere, you can train people, they can do it. There's not a problem at all. But the thing is how to do the analyses and the cataloging. And this is really where our experience, which has been like more than 150 years in this, can really be transmitted to really tell how to do it wherever it is.
Very good. Dr. Davis, Dr. Montorzi on that?
Sure. I would like to add that precision medicine requires multiple domains of information, of which genetics is just one of the recent ones. However, there are other domains that are equally important, like the location where the patient was born. For example, there are parts in the world where arsenic is very common, that changes the prospect of that patient for developing, for example, certain cancers. The location where the patient lives, that's also important for some predictive analysis, for example, exposure to certain contaminants that may lead to lung disease. So all that information is important for medical decision making. Precision medicine, even though there is a current emphasis on genetics, it requires access to every single piece of information that gives a very good description on who the patient is, where the patient comes from. That information can be acquired through technology, like Ghassan mentioned, for example, with a highly advanced laboratory, but also that part of that information can be obtained by the local physician, understanding what are the circumstances where that patient was raised, where that patient has lived. That information is not available to us in Boston. We need that collaboration in order to provide personalized precision medicine to that particular patient. Nowadays, patients go from one city to another. This pandemic will be over at some point, probably soon. Patients will continue traveling, and any doctor who sees a patient will have to have access to that information in order to make the right decision at that moment. It can be due to chest pain, or it can be due to cancer, it can be due perhaps for preventive reasons. That information has to be exchangeable between systems. That is a challenge. In the United States, we are moving in a direction of sharing electronic information. We need to find ways to share that electronic information between countries. That's something that will require collaboration between governments.
And I just like to maybe chime in there on that note, and something that came from the previous panel, and very relevant to the location of this Jericho facility. We helped build a radiation oncology program at Augusta Victoria Hospital, which is the East Jerusalem, in collaboration with the Hadassah Hospital.
I see.
In cancer care. And on that radiation oncology theme, it was mentioned, I think in the last session, talking about doing distance surgery. I think Ghassan, I can't remember who was talking about that, but in fact, we have a radiation oncology program in Bermuda where we are able, in a compliant way, to actually do all aspects of planning and delivery of care over a distance. So with each element in the diagnosis and treatment, there really is tremendous opportunity. I'll say one other quick thing, which is on the compliance side, that doing this correctly means being really meticulous about local compliance between all of the parties. But after going through all that, as Dr. Montorzi is saying, the benefit is tremendous.
So we have some questions from the audience, but I want to ask you one more myself, which is a lot of cancer, I know from personal experience, cancer care depends upon non-medical factors, not technological. What I mean is depends on family support, depends on faith, depends upon the willingness to live and to fight through the problem. We know that's true. You've dealt with many, many, many patients and families. It's not just the medicine, right? So the comment is, by providing a community center where the language is familiar, the cultural amenities are, even the food, the religious services, the ability of the family to live in a bungalow on the grounds for 6 to 8 weeks, if necessary, depending on the treatment, obviously, that's being required. Please comment on how useful you think that might be. And I'm not trying to just ask you for a rhetorical answer, but if there's any specific comments you'd like to say, perhaps on what would be the most important aspects of the non-medical aspects of treatment of cancer.
Yeah. Well, thanks, Rob. They're all important. Excellent point. And if anything, we totally agree, all of us, that they are all very important. Medical care is really kind of, will encompass the patient from every perspective. As we say in medicine, we don't take care of diseases, we take care of patients. And if anything, every perspective is needed. And by all means, whatever is necessary to really enhance the opportunity for patients to heal and get better. And this is beautiful work that was done actually at Mark's institution, where they found actually that social support for patients with breast cancer, these patients will fare way better than the patients without that social support.
Very interesting.
And if anything, here at Memorial, patients are offered the diet that really is pertinent to their religious or medical needs, or even cultural needs. We have the department in regard to the different denominations in regard to religious needs to visit the patients. And we might even enhance even opportunities that are needed, like celebration of holidays and many others. Along that line, just to kind of fascinate you, you probably know my wife is actually a physician also at Memorial, Dr. Aline O'Reilly, and she's Irish. And 4 years ago, I had a very serious car accident while I was visiting the American University of Beirut, part of the joint effort that we do. And, thankfully, as you can see, I'm okay, but I had to be in the ICU for 2 weeks at the American University of Beirut, and then I was brought medically here to the US. And what's fascinating and touching is that at the American University of Beirut, the team came apologizing to my wife that they could not find an Irish Catholic church on Sunday. Will it be okay if it's not Irish? I mean, that's exactly what medical care is, to make sure that you address every perspective.
Thank you. Anything else on that, gentlemen?
I think that sums it up well. We've also seen that culturally, they were talking about family. There's just this remarkable sense, particularly in the Middle East, of family cohesiveness, of family obligation, being around family. That family has the absolute obligation to seek the best medical care possible, which leads to a lot of travel at different times. So I think your point is well taken about really the core of the critical nature of that, generally in care, but I think specifically in this region.
Let me see if there's a question here that we can answer in the time we have.
Rob, could I just suggest that the one question I think that may go right to the heart of the project is by the anonymous person who submitted it, about finding out more information and about what they can do in terms of donations to help you get your project going.
So Mr. Anonymous or Miss Anonymous, contact me at my email, if you like, at Rob K, I'll put it on the chat, at Intelliversity.org. And if anyone wants to help or has any advice or counsel, I'd be open to it. Bob, see, Castro asked about diasporas and refugees. He says, people, as we all know, they're refugees and travelers from around the world that share genetics with some ancestral population. How do we aggregate, he says, how do we aggregate the knowledge for a treatment of people everywhere? Any comment on that? Does this require some new computer systems that are internationally available
I
worldwide?
would say I'll take a stab at that because we really deal with this all the time. It is an important thing to do. It is the right thing to do. It is really a political and social issue, in many cases, much more than a technical issue. How do we in the various societies agree to share data in a way that our leaders and our individuals feel are appropriate? So I think people deal with this with anonymous data in certain circumstances, but as was pointed out, sometimes you need specific data for different folks. An area of active discussion, critically important. I think we're a ways from being able to solve it, but progress is being made. But it's much more of a political and social issue than truly a technical issue at this point.
Interesting. And the two move in parallel, because if you look at the state of genetic knowledge even 1 year ago, let alone 10 years ago, as applied to cancer and precision care, it's night and day from 10 years ago. And we're nowhere close to knowing enough about the genetics and how it affects treatment, right? Not even close. We can't answer all the questions, so I'll ask you, anyone who has another question, to contact me personally or one of the members of the panel. And I think I have to turn this back to you, Ransel, where our time is up at this point.
Well, thank you, all of you. It was wonderful and very fascinating, and congrats, Rob, on a very bold and visionary project, one that I think will further bring all of us together for the greater good. So you're to be congratulated. Thank you.